like to share one thing that when we started with this program, this is actually an interactive program, and it spread for 2 days with somewhere around 24 topics with 8 tables in it. But unfortunately, because of the COVID situation, we were forced to switch to online platform, and the very purpose of this module was changed by that. Because on online sessions, the interaction which is expected, we are not able to get that interaction, and that is the problem where we were not very much happy with starting this program on this platform. But ultimately, we didn't had choice because there was so much of time which was gone because of the COVID, and we were not able to deliver the scientific contents which were been prepared. So we agreed with modified version of this program. We adjusted the program to the online version, and we brought this module in front. Today, there are a few modifications in the program which we have declared earlier. Dr. Santosh Son's laptop has been not working. I think it fell into yesterday and broke down, and so he was not able to join since he was out of station. That was the only source where he could have taken the course, and that's why I was been asked to take the lecture. The second change is probably Dr. Rajkumar Gupta is not going to be there in the topic today because his nephew is suffering from COVID and he is not well. So he is not going to be there with us today. To begin with, sorry. Yeah. Early recognition of a critically ill child is what is most important, because most of the children are referred to the ICUs are very sick. Usually they are for two reasons. Either it is a respiratory failure or cardiac failure. And generally when they reach at this stage to the PICU, the outcome is usually dismayed. We have to have a system where they are picked up early, treated early, and probably if not treated, they are referred early, so the outcome improves in these cases. So early recognition and transfer of a stabilized child is what is aimed at this moment. There are many ways in which a critical child means a child which has become critical presents to us, and the first system which gets affected is most of the time respiratory system, second cardiopulmonary, and probably by the time it reaches to the ICU, both cardiorespiratory systems are affected. In respiratory system, if you see, oxygenation and ventilation are the two parameters which are affected most of the times. First, the oxygenation, and in due course of time, ventilation. Whereas perfusion system, when it gets affected, the nutrient which are need to be supplied to the body or organs uh, for the aerobic metabolism are hampered, and that ultimately leads to cardiopulmonary failure and then to arrest. The assessment involves primarily physical examination, that then leading to classification of the physiological status, and third, deciding the management priorities. If you have attended the PALS course, uh, probably this is a little bit of summarization of the PALS first topic, which is assessment of sick child. We have kept the same concept because that is the quick and best way of assessment of a sick child. I am not talking about a patient who has come in the OPD where he has come with cough, cold, fever, or loose motions. But when a sick child is coming, definitely this is the best way to assess, because it gives you, instead of going for a diagnosis, it prioritizes your actions for life-saving measures instead of going for diagnosis and treating the element. After assessment, the second part which remains is the monitoring a critically child, and then the serial assessments which are required for that patient. Assessment, how do we do that assessment? There are four things which we need. General assessment, which we do with the help of a PAT triangle, or pediatric assessment triangle. And it takes hardly first few seconds just on seeing the patient when the patient enters into your room, just by the assessment of appearance, work of breathing, and a rough circulatory assessment will give you a general assessment of the patient to triage whether the patient is really sick, or can take some time, or is absolutely stable. The second thing we do is primary assessment. And here the ABCDE approach is used to evaluate the vitals and the pulse oximetry. Then the secondary assessment, where we go for focused medical history through sample method and examination. And the tertiary assessment is investigation. Now, in general, when we approach a child in our OPD, first thing we take is history, examination, then we go for. But here in this format, we change the assessment pattern because we need to triage the child depending on his need. Probably, just a minute. Yeah, depending on his need of the severity which he is suffering from. Coming to PAT triangle, what are the visual and auditory clues which we take from the PAT triangle? Assessment is where we look for the muscle tone, how the child is interacting with you, whether he is responding to your oral commands or not. Look for the consolability, look, gaze, and speech or cry if the child is less than 1 year of age. These are the few things which will help us in assessing the appearance of the child. AVPU scale is one more thing which we look after for assessing the mental status. But in general, when the child comes to you, I think these are the few things which you should look for. Work of breathing is the second important thing. And whether it is absent or with effort, whether some abnormal sounds are present or not, audible sounds, not with the help of stethoscope. If suppose the child is grunting in front of you, and if he is having retractions, nasal flaring is there, subcostal retractions are there, these you need to assess and decide what kind of what kind of problem the child is facing. And circulatory, definitely color of the skin, whether he is bleeding from somewhere or not, whether the child is pale or whether the child is pink. So appearance, work of breathing, and circulation is the PAT triangle which gives you the initial appearance of the child. Then we go for primary assessment. In primary assessment, here we touch the patient and see, instead of just evaluating on visual inspection, we see the patient by touching the patient and evaluating. We look for airway, breathing, circulation, disability, exposure, and these five things will decide the further course of action of the child. First, airway. We always decide whether the airway is patent or not, and we use look, listen, and feel to confirm the patency of the airway. And we decide ultimately whether the airway is clear, which is open and unobstructed. There are no sounds, the breathing is normal. If you feel the movements of the chest, they are also normal. So in these cases, you can say that the airway is open and unobstructed. There are some conditions where the airway may be clear but not maintainable, or may be maintainable. If maintainable by simple measures like lying on one side, uh, lying on one side, that can help us to maintain the airway. Am I audible clearly?
Sir, yes, sir.
Am I audible?
Audible. Yeah, clear.
Yeah, okay.
Yeah, clear. Yeah.
Sure. And whether it is not maintainable by routine measures, by keeping on the left lateral position, or by simple measures, just by lifting the head lift, chin lift method, then in those cases we need advanced measures to maintain the airway, and that will be where we need to intervene as quickly as possible. So airway we decide by auscultating and seeing the patient and feeling also whether it is clear, maintainable and non-maintainable. And depending on that, we take the decision whether we need to. If it is clear and maintainable, we don't have to do anything. But if it is not maintainable, we don't go ahead with assessment and we immediately intervene there itself so that we can improve the outcome. Coming to breathing, and breathing evaluation we'll do with the help of respiratory rate, respiratory efforts, tidal volume, airways and lung sounds, pulse oximetry. Respiratory rate is generally where instead of looking just for respiratory rate, we try to look for simultaneously whether the child is increased rate is what we are most of the time looking for. Tachypnea is where we look for, but there are many physiological reasons also, like anemia is there, or probably fever. The child is running fever and the respiratory rate has increased. Other than the pathological causes for increased respiratory rate. But what is more problematic is bradypnea instead of tachypnea, where probably the child has come to a stage where either his central nervous system is affected or he has been fatigued to such an extent that he don't have enough of power to take effective sufficient breaths for himself, and there the bradypnea needs to be assessed. Coming to respiratory efforts, in respiratory efforts, as we all know, in infants, most of the time, instead of retractions, first thing which comes is the nasal flaring. Suprasternal retractions, depending on where the obstruction lies. Subcostal, intercostal retractions, we need to see to assess the severity of the respiratory failure or probably distress. Tidal volume normally 5 to 7 ml per kg, but that is all theoretical or when we are taking the patient on ventilator. But when a patient is lying in front of you on your bed to assess the tidal volume, the best method to assess is to see the lung expansion or the movements of the chest which are taking place. If they are equal on both the sides, whether the sufficient quantity of lung rise or chest rise is there or not is the way we have to assess. But there is no objective way in which we can assess. It has to be a subjective thing, which with experience we come to know. Airways and lung sounds. Definitely, when we auscultate, we have to see whether the air entry is equal on both sides or not. Simultaneously, the lung sounds are whether bronchial breathing is present at some sound or adventitious sounds like uh, creps are present in particular area to see whether parenchymal disease is involved, or to look for simultaneously V's which suggest that more of instead of parenchymal the airway which is affected. And the last but not the least, the pulse oximetry. This has become a very important tool nowadays, and with the COVID coming into picture, everyone is obsessed with pulse oximetry. And the good thing about pulse oximetry is it detects low oxygen saturation before clinically apparent cyanosis or bradycardia appears. And SpO2 more than 94 in room air is adequate oxygenation, and less than 90 on 100% O2. Definitely you need additional intervention more than just supplying oxygen to the child. Then you need to go for higher interventions in terms of either HFNC or non-invasive ventilation or invasive ventilation, depending on uh, the scope of your practice and the need for the patient, depending on the disease. If you see saturation versus partial pressure of oxygen, the oxygen dissociation curve shifts to right with increased temperature, increased 2,3 dpg, and increased acidosis. So in such cases, at even higher PO2, the SpO2 will be low, even if the PO2 is high, because the dissociation won't take place, and in that cases, it will be a problem. Uh, just a second. Yeah. Coming to circulation, assessment includes evaluation of cardiovascular function, and it can be done in two ways, either by looking at some parameters which we can calculate directly, or we ultimately look for what is the aim of that circulation is the end organ function. Just a minute. We'll look for heart rate and we will look for whether tachycardia or bradycardia is there or not. Peripheral and central pulses and blood pressure. Blood pressure to assess whether hypotension is present or not present. That will decide one of the important crucial things which we need to follow. In due course of time, I will come to that thing because the compensated versus decompensated shock are to be decided on the values of the blood pressure which are age appropriate for that patient. Now, end organ function, mainly we see for three things, whether the brain perfusion is good, in that mental status, if the patient is awake, responding to oral commands, no confusion at all, then we can say that the mental status is good and the brain perfusion is normal. The skin perfusion which we look for is capillary refill time, skin color and temperature. Renal perfusion at the outset may not be beneficial because the shock might have progressed recently and the urine output has been collected from some time. So immediately, even if the patient passes urine, it may not be suggestive that the renal perfusion is good. But in due course of time, once you observe the child for some time, then definitely the urine output can be a good measure to assess the outcome. Now coming to secondary assessment, and secondary assessment is done by sample method. In that we take focused, S is for signs and symptoms, focused history, focused physical examination. Then aim is to gain information that explains impaired respiratory, cardiovascular or neurological function. In short, up till now, what we have done is we have assessed first initially we have triaged whether it is very critical or routine child, which can take some time to be treated. Second, we assessed whether the vital functions of the child are normal or not, depending on the respiration and the circulation. And then we are doing this thing to look for further impairment in the cardiorespiratory and neurological function. Simultaneously, here we will be looking for the etiological assessment. Till now, we were not looking for etiological assessment in these cases. And how we do that is by the sample method. In that, signs and symptoms, S, A for allergies, M for medications, past medical history, last meal and events. Most of the time what happens is we start with signs and symptoms, but our eyes are looking for what we assessed in the first few slides on the PAT triangle. But simultaneously, while speaking to the parents, we speak on, tell me what happened. And we are assessing on, though we have classified here in different ways, but we are assessing the child with our eyes. Simultaneously, we are asking the parents about the sample history. Allergies, definitely. Medication, most of the time they have been treated by the family physicians for a few days and then they reach us in this cases. Past medical history, few diseases which are having such records may be complicated with, like suppose if the child is having a known history of diabetes and he comes with distress, then the things become easy. Last meal and events leading to this problem are to be well vetted so that the complete story is known to us and we can take a judgment according to that. Tertiary assessment does not mean that it is to be done at the end. Some of the things we need to do right in the beginning, but it is to detect and identify presence and severity of respiratory and circulatory abnormalities. And probably here we also look for the etiological diagnosis also, and accordingly we investigate. Here, that does not mean that third in order, but it is depending on the situation. If we are suspecting a hypoglycemia, we can do the RBS right in the beginning instead of waiting for its turn to come after doing the sample history, and then we look for RBS. We met by that time, we most of the time we order the staff to get an RBS done by the time we do the assessment, and so many things we do simultaneously instead of doing it in 1, 2, 3, 4 order. Probably we all are doing all these things all together at one time. We are doing 2 or 3 things at one assessment. The way of presenting is here we are presenting is in this way, but most of the time we do it all together when we see a critical ill child. After we go through these 4 stages of general assessment, primary assessment, then secondary and tertiary assessment, we need to categorize the child and what categories the child will be falling, whether the problem is respiratory or circulatory. If it is respiratory, whether it is upper airway obstruction, lower airway obstruction, lung tissue disease or disordered control of breathing. And if it is circulatory, we need to find out what kind of shock the child is suffering from. Either it is hypovolemic, distributive, cardiogenic, obstructive, or a combined variety of this. Depending on the type, and after that we need to assess the severity also. First we have decided the type, then we decide the severity, whether it is respiratory distress versus respiratory failure, and in this compensated shock versus uncompensated or hypotensive shock. Here the role of the blood pressure comes into picture. The moment the blood pressure drops, we classify it as hypotensive shock. Even if you have all the features of shock, but if the blood pressure is maintained, you can put it in compensated shock. As soon as the blood pressure falls, the class changes to hypotensive and the severity increases. And most of the time we have a combined presentation. It is not like we will have only respiratory or we will have only circulatory. To begin with, it may be, but in due course of time, by the time we see the child, both the systems are involved together, and that leads to cardiopulmonary failure or cardiorespiratory failure. Thank you very much. Arul Kumaran sir. I think